for a webinar about the future of healthcare access in Ohio. Today we're going to hear from 3 issue experts about the status of healthcare in Ohio, what we're hearing at the federal level, and how that could impact the process at the state level with the upcoming state budget. If you've never been on a webinar with Advocates for Ohio's Future before, I want to share a bit about who we are. So we are a statewide coalition of over 485 organizations and thousands of individual advocates like you who focus on making Ohio a great place for Ohioans to live and work. So that means that Ohioans should be able to participate in the economy, they should be healthy and safe in their communities, and they should also be able to afford the basics like food, rent, housing, and transportation. All right, and we hope that you'll continue to advocate and listen with us after the webinar. As I said, after the webinar, you'll be receiving a follow-up email with the slides, recording, and other resources. And we'll also include you on our email list going forward, where you will receive periodic email alerts, invitations to other webinars, and where we can share new resources that help you advocate for good public policy in Ohio. You're welcome to unsubscribe at any time using a link we include in every email. All right, today you will be hearing from 3 presenters about different aspects of the status of healthcare in Ohio. First, you will hear from Loren, Anthes, Public Policy Fellow at Medicaid Policy Center for the Center for Community Solutions. Also from Wendy, Patton, the Senior Project Director for Policy Matters Ohio. And lastly, from Brandi, who is the Chief Executive Officer of Voices for Ohio's Children. So without further ado, I will turn the presentation over to Loren to get us started with an overview of Medicaid. Loren, you ready?
And I am. All right, thank you, Becca, and welcome everybody. For the first portion of the presentation today, what I'd like to do is just provide some of the nuts and bolts of the Medicaid program and give you some context as to where we are and potentially where we might be going. So first things first, Medicaid's a pretty deep policy topic. So wherever you see that little logo of ours in the upper right-hand corner of a slide, that means there's more information available on that topic at communitysolutions.com. And if you're interested in Medicaid policy more specifically, you can go to communitysolutions.com/Medicaid. All right, first I'd like to just sort of set this foundation, and many of you may recognize this phrase, that if you've seen one state's Medicaid program, you've seen one state's Medicaid program. And in many ways, that's the policy context for Medicaid generally. Being a state and federal partnership, it's a pretty complex set of policies and fiscal relationships and ideas that get worked out between the federal government and the state. So, some have referred to it, and I certainly do, as a Rube Goldberg machine. And so when we think about what could happen on a state level or a federal level, realize that it can often be very complex. So today I'm going to try to break down this machine just a little bit more. And what I will cover are the 5 W's of who, what, where, when, and why, the money associated with Medicaid, and a quick review of the state's Group 8 assessment. And Group 8, for those of you who may not read Roman numerals or who aren't familiar, is the Medicaid expansion. All right, so the 5 W's and 1 H. So who? So you may recognize a chart on the left or something similar to it. It just explains the idea that Medicaid is a combination of categories of individuals and income eligibility. So unlike Medicare, which really only deals with, say, age and is financed through a relatively simple mechanism, Medicaid is much more complex, and it changes from state to state. And so when you look at something like childless adults, which is another way to talk about the Medicaid expansion population, eligibility for their inclusion in Medicaid falls below 138% of the federal poverty level. So for an individual, that means for an individual, their annual income is about $16,394. So it changes based on family size, it changes depending on who you are, and it changes depending on how your income gets counted. All right, so the what? Basically, Medicaid is a combination of federally mandated and state optional services. So the federal government says you must cover certain things, and then the state has the ability to add other optional services. And oftentimes states add services to lower the cost curve, or because there's been some effort to increase access to certain services that might make sense for whatever community or state that you might be in. So a good example of this is home and community-based alternatives to facility-based care. These are the sort of waivers for the elderly to get out of nursing facility settings and into lower cost and tend to be more preferred by consumer settings of, say, their home or some other sort of community-based environment. This is a map I put together with data at the end of the year from the state of Ohio, and this shows the coverage that Medicaid represents relative to the total population of a county. So you look at Vinton County, nearly 40% of the entire population is covered by the Medicaid program, and you can see that the county average statewide is around 25%, which means that the state of Ohio covers 1 in 4 individuals. In fact, nationally, Medicaid pays for 1 in 2 births. But what you can see is that Medicaid, in terms of health care coverage, provides a disproportionate amount of that sort of coverage to the south central part of the state, or south central Appalachia. And this is an important sort of stat, this is me kind of just taking the total annual spend and dividing it by minute, but you can see that Medicaid spends $48,000 a minute, which is the political context and the policy context of the program generally. Whatever side of the spectrum you may lay on, it's important to understand that there's a lot of money in this program, and a lot of people count on the program. So what does it mean to be efficient, and where should those resources go, and how do you get there? That often creates the political landscape for a lot of the conversation. All right, why? Now, I know these are sort of hard to read, but the red map shows you teen births per 1,000. The blue map shows you infant deaths per 1,000. And the map on the right, the pink, shows you the most common primary drug of choice as heroin or some other opiate. And you can see that these maps share a lot of similarities. So when you talk about public health issues, issues that people might just be generally familiar with, or at least aware of, when you talk about teen pregnancy or infant mortality or the opiate epidemic, you can see here that there's a lot of correlations between poverty, where poverty is concentrated, and where these public health issues are. So how does the state implement its program? Well, it's through essentially something called a state plan, which is the contract that exists between the state of Ohio and the federal government, and there's some basic outlines of what the federal government expects on the right, and you can explore the state plan on the left, although I would say even though there's sort of the 7 sections and it seems pretty compact, it could probably take you a number of months to actually read the whole thing. However, whenever you have a certain question about how Ohio does something, or what the expectations are between the state and federal government, this is an incredibly helpful resource, and you can see the link there below if you have any more detailed questions about how the state operates its program in conjunction with the federal government. But beyond the state plan, there are also waivers, and you can see our symbol in the corner. We wrote something about the Healthy Ohio waiver, which is an 1115 demonstration waiver for those Medicaid geeks out there that sought to increase cost-sharing requirements on Medicaid enrollees. And basically, waivers are ways for states to do some innovative things outside of what's typically allowed in federal law or in the state plan, and tries to leverage sort of these new service delivery tactics to create an efficient program to increase health outcomes overall. And Ohio has already taken advantage of a number of these, including 1915B waiver, which has allowed managed care to exist in the state of Ohio, and then the 1915C waivers, which is what we described before as the home and community-based service waivers for individuals who are elderly or disabled. All right, so now let's get to the money. And I borrowed this graphic from the Health Policy Institute of Ohio, so thank you. But it's important to understand that the federal-state partnership is fundamental in how we think about the state budget and Medicaid overall, and also how the federal government views Medicaid as an entitlement. And you can see here that, for the most part, the federal government foots most of the bill, and this is where, if, say, for every dollar Medicaid spent in the state of Ohio, 64.5 cents would come from the federal government. And this amount changes depending on what program you're talking about. So with Medicaid expansion, for example, up until this year, actually, 100% of that program was completely federally financed. And that offset some of the state obligation for other programs. So, an example of that might be the home-based Moms First, or the Moms First program, which involves some home visitation programs for pregnant women. That was reimbursed at 90% of the 90% of this federal match. It went to 100% with the Medicaid expansion. Therefore, they were able to expand it. So understanding how these dollars shift and where they come from is an important aspect of how the state of Ohio views its budget and how the federal government views its obligation in this program. And over time, you can see that the federal match has increased more significantly than the state's obligation. And I highlighted 2014 because you can see where in 11 through 13 that number had been ticking down. It has started to tick back up, and that's likely due to the expansion of the Medicaid program, which, again, was 100% federally financed. And when we look at Ohio overall and state budget, oftentimes we hear Medicaid is the Pac-Man of state budgets. And while it has grown over time, the thing that I want to take away from this is that, it's often federal dollars. In fact, Ohio has a $25 billion Medicaid program. Only 1 out of 5 of those dollars are actually financed through state taxpayer money. The rest comes from the federal government or comes from fees set to providers like hospital systems and nursing facilities. So while it's big, and it's certainly a part of the state budget, it's always kind of been that way, and it's really increased due to this increased federal dollars that have flown down in the state. And where does that money get spent? And this is going to be an important thing to understand when we talk about how you would want to reform the program, whether you're talking about block grants or per capita spending on the federal level. Most of the money that gets spent is with a minority of the population. It's aged, blind, and disabled population. So folks in nursing facilities, folks with more acute care needs. While they only represent 12% of the population, they represent nearly 1 out of every $2 that are spent. So when we think about what the question is for policymakers about how to make this an efficient program, let's say that part of it would be, okay, let's eliminate the Medicaid expansion. Or is Medicaid expansion really helping control costs? Well, even if you eliminated it entirely, a lot of the spend is still not in that program, especially when you're talking about state dollars. So getting to the Medicaid expansion more specifically. So here are those maps once more. And on the right-hand side, you can see this is updated through, I believe, November. Percentage of the population on Medicaid who have enrolled through the Medicaid expansion. So you can see there's a lot of similarities. And in fact, whether you're talking about infant mortality or the opiate epidemic, Medicaid expansion has filled in that role of providing coverage to address some of those issues. In fact, I think yesterday, Harvard University released a report that said out of the 700,000 Medicaid expansion enrollees, about 150,000 of them had some sort of substance use disorder. So when we talk about the access to treatment and when we talk about the mortality associated with this disease of the despair, as my boss likes to talk about it with opiate abuse, you can see here that this is where a lot of filling in the gaps takes place, is through this type of coverage. And so what are the results? So in the last budget, state budget, the legislature said, okay, the Ohio Department of Medicaid, we need you to assess how the expansion is going and what are the results. And you can find a copy of this lengthy report on their website at medicaid.ohio.gov, but I've also sort of compiled something that's more brief, sort of a Cliff Notes version for you on our website. But you saw that access increased, and it benefited mostly white unmarried men with a high school diploma or less. And that the outcomes were significant. Half reported an improvement in health, and many reported greater ability to manage chronic diseases, which is where a lot of the cost lies in the Medicaid program. And then we talked about other results, rural impact. We have a report out there about small cities and small towns and big cities that our former executive director did, and he took a look at 47 small hub towns across Ohio. And what we noticed is that a disproportionate share of the population in these places had coverage through Medicaid. And more than that, it was an economic engine for them, because out of the 47 small towns we looked at, 35 had a hospital as a major employer. And according to the Journal of Health Affairs, those hospitals are more sort of economically sensitive to Medicaid expansion or Medicaid coverage generally. And then you can look towards other research by the National Bureau of Economic Research, which shows that Medicaid has created greater economic mobility over the course of its life, even since 1965. And then specifically with Ohio's review, it showed that it supported working and addressed some of those social determinants of health, like housing, the ability to purchase food, and medical debt. And while 40% of the Medicaid expansion enrollees were working, many stated that they would be more likely to seek work if they were unemployed. And of those who were unemployed in this very large survey, half of them had indicated for some sort of mental health or substance abuse issue, which is significant, because then when we're talking about, well, who should or should not have coverage and what would the requirements be, the question is, well, what is the severity of the disease? Is there a provision around medical frailty? So there's a lot of questions that would come out from that. And then obviously money is something that people are always concerned with, like we talked about previously, and this is my last slide here. But over the last year, when you think about what Ohio had done in terms of what they expected to spend, they've been very efficient with their program. So overall, Medicaid has underspent by nearly $750 million, and in Medicaid expansion alone, in the last 6 months, that has meant about $100 million. So it's very efficient the way it's managed, and with Ohio sort of collecting less in terms of tax receipts, this has often bolstered the cash flow of the state, something which the budget director has mentioned previously. So a lot of details here, I know, and obviously there's more information available on our website. But with that, I want to say thank you, and I would be more than happy to answer whatever questions.
All right, thanks, Loren. And now we will hear from Wendy Patton with Policy Matters Ohio.
Thank you, Rebecca. I'm going to talk a little bit about the Affordable Care Act, also known as the ACA, and how it has significantly broadened access to health care and benefited Ohio, even though some may not realize how. 900,000 more Ohioans have health coverage now than they had before the Affordable Care Act was put into place, and more than 3/4 of that 900,000 is through the Medicaid expansion. In 2009, 5 million Ohioans had what could be considered a pre-existing condition for which they could be denied health coverage, and that has been prohibited. 4 million had lifetime cost limits or caps on coverage. You really don't want to hit that cap when you're in the middle of cancer treatment. That has been prohibited. Today, as a result of the ACA, Ohio has one of the lowest rates of any state of uninsured, 6.5%, compared to the national rate of 9.4%. So the ACA goal of broadening access to health care has worked in Ohio. The next slide is a graphic that shows you where Americans get health coverage. You'll see that employer or group plans provide coverage to 46.1%. It's the area in sort of red that highlights, it's sort of a pinkish color. It highlights the share of the population that's served by the Affordable Care Act and where this health access has been broadened substantially. It comprises 7.2% of the American people. Next, please. The repeal of the Affordable Care Act would clearly hurt in a lot of ways. The greatest loss would be on those who gained health care access, that's 7.2%. In Ohio, that's 700,000 who gained coverage through the Medicaid expansion and about 212,000 who had help buying insurance on the health care exchanges with the help of tax credits and subsidies. Now, you may have been surprised to learn when Loren told us that the majority of the Medicaid expansion enrollment in Ohio was white, 72%, male, 56%, and had less than a college degree. This group has alarming health problems. Lifespan has been going down instead of going up. Medicaid expansion can help this. The governor's report that Loren highlighted found that enrollees established relationships with doctors that they could go to regularly, and they have reported better emotional health, and financial stability. This is if the ACA is repealed, this is the greatest loss. There will be other challenges. It's not really true that we don't exactly know what a repeal of the Affordable Care Act would look like. Last year, the Congress sent a repeal plan to the President, who vetoed it. With just 2 weeks to go to identify a plan to go with this repeal, you can bet that some of that plan is going to look like what was delivered to the President last year. The Urban Institute looked at that plan and evaluated what the impact would be on Ohio in 2 years, in 2019, and found that in that year the state budget would lose $3.5 billion federal dollars. $535 million would be lost to the Ohio economy in those healthcare marketplace tax credits and subsidies. If the ban on discrimination against people with pre-existing conditions and the prohibition of lifetime caps are retained, but the requirement that broadened the market, the requirement that everyone participate in health care, is eliminated, insurers will face financial difficulties that could cause many to drop out of the individual plan market, and when the tax credits and subsidies vanish, the market will further disintegrate. The Urban Institute estimates that nationally, in addition to the 22 million people that will lose immediate coverage, another 14 to 21 million could lose coverage as the insurance markets disintegrate. Because most of us have health coverage under the Affordable Care Act, hospitals now get paid for the care they give. Thanks to the ACA, Berger Hospital in Circleville, for instance, saw the cost of uncompensated care fall from 30% of payments to 14%. A major employer in Pickaway County, this allowed Berger to expand employment and stabilize finances. With the repeal, the uninsured once again come for emergency treatment to the hospitals. If federal payments to help with this uncompensated care is not restored to pre-ACA levels, hospitals again face real financial danger. The American Hospital Association estimates that Ohio hospitals alone could lose up to $15 billion between 2018 and 2026. Well, who would feel the brunt of this blow? The Medicaid expansion has helped millions of workers in Ohio's largest job groups, which are mostly low-paying: retail, restaurant, food service, janitorial. These are people we see every day in the child care worker at the daycare center, the aide at the nursing home, the cashier at the grocery, the server at the McDonald's window. This is not a faceless group. We know the people who will be hurt. 43% of Ohio's Medicaid expansion enrollees are working. For those who are not working, 3/4 last year were looking for a job. Enrollees reported health care can help them keep a job and look for a job. So the ACA benefits employment as well. The current financial structure of the Medicaid program is crucial to its success as a program. If your level of income makes you eligible, you can access treatment. It's a true partnership between the state government and the federal government, as Loren described. The program is flexible, giving states considerable leeway to decide on services and waiving rules for program changes deemed to help people see a doctor and get healthier. It is countercyclical. If you're income eligible, you get coverage. So when a recession hits and people lose jobs, yet demand for Medicaid rises, the state-local partnership supports that increase. This keeps people healthy and prevents medical-related financial disaster for individuals, families, hospitals, and communities. There have been proposed changes in this structure, and with the repeal of the ACA, we can expect the proposals to change the current structure of Medicaid from a partnership to a block grant. We've seen this before. The change of aid to families with dependent children in 1996 from an eligibility-based partnership to a block grant has had devastating effects on the program. In 1982, 82% of families eligible for AFDC in the income eligibility program structure were helped. In 1996, as the program was changed to a block grant, that share of eligible families that were helped fell to 68%. As states used the new flexible block grant program to backfill for state dollars and established waiting lists, sanction policies, and the kinds of program rules that have almost eliminated this kind of aid in Ohio and other states. In 1996, only 68 out of every 100 eligible families were helped. In 2014, just 23 out of every 100 eligible families was helped in the TANF program. The figure that you see on this slide illustrates how fewer children now are getting aid for which they are eligible for the TANF block grant. It's even affecting aid to children. 40 out of every 100 children eligible for TANF aid in 2009 were served with help of the federal stimulus dollars. In 2012, that had fallen to just 28 out of every 100. This is the kind of pattern we may expect if Medicaid is turned into a block grant. If confirmed, President-elect Trump's nominee for Health and Human Services Secretary, House Budget Committee Chair Tom Price, will be well-placed to advance a proposal that he supported as part of the recent House Republican budget plans to fundamentally change the structure of Medicaid by converting it to a block grant. Repeal of the ACA is expected to knock 22 million Americans out of health coverage. Block granting, again, will knock another, is estimated would take another 14 to 21 million additional people off, they would lose their Medicaid coverage. The block grant is specifically designed to save the federal government money, sometimes at the expense of the state. Another configuration called per capita caps is sort of a middle ground, allowing growth in the number of people served, but with limits on costs within a category. Speaker Ryan's, quote, Better Way health plan, which much of the change in Medicaid may be modeled on, would give states the choice of a block grant or a Medicaid per capita cap. Both would appear to enable states to make sizable cuts directly affecting beneficiaries that they can't make now. This could include waiting lists, capping enrollment. The states would be permitted for the first time perhaps to impose a work requirement and terminate coverage for people who are deemed non-compliant, resulting in people with serious barriers to employment losing access to health care. The Healthy Ohio plan we fought against last year with its premiums and lockouts could be allowed under this plan. Research indicates up to 15% of enrollees would drop out under such provisions. This is part of the reason it was not accepted under the current Medicaid structure. That oversight likely goes away with the block grant program. And this final slide just illustrates the Congressional Budget Office's estimate of how cuts to the Medicaid program are likely to grow over time under the House Budget Committee block grant. While the block grants might grow by the rate of a consumer price index, the rate of medical inflation is much, much higher and erodes the value of a cap year over year, diminishing the ability of the Medicaid program to make Ohio and Americans healthier over time. Thank you.
All right. Thank you, Wendy and Loren. Before we move forward and hear from Brandi about the impact these changes will have on Ohio kids, we're going to pause for a couple minutes to answer a few questions. So if you want to type any questions you have up to this point in the chat bar, you can do so now. All right. All right, well, it looks like we don't have any questions up till now, so, here's one from Elizabeth. How quickly could the repeal directly affect Ohio's Medicaid expansion?
We don't really know that answer at this time, but it's people largely assume that it would be put off by a couple of years to allow the health system some time to plan for and adjust. The analysis of the Urban Institute that we've been studying assumes repeal takes effect in 2019.
And if I can
All right,
add
we
on
have
that,
another.
Wendy. Oh, I'm sorry. Just one thing. Beyond the repeal and replace policy, something that should be paid attention to just from a business intelligence standpoint is probably what the administration is able to do through the utilization of things like waivers. The appointment of Seema Verma to the post of Chief of Center for Medicare and Medicaid Services is significant because she worked on Indiana, Kentucky, and Ohio's 1115 waivers, which sought to increase cost sharing for enrollees. So regardless of what happens with the ACA writ large, there's a number of things that could likely take place through administrative processes beyond what Congress is able to control.
Thank you, Loren. And we'll do another one more from Mark and Kara and Patty. I see yours. We will get to yours after Brandi does her presentation. So the question is there an increased threat to optional benefits, for example, vision and dental?
And I'll let Wendy weigh into this as well. I think if you look at the one slide that I had around federally mandated services and state optional services, and you combine that with populations in terms of who is interested where, I think that all of these things sort of blend themselves together. So, whether or not federally mandated services are sought to be waived by states, or even in Ohio, or if other services that may not seem as necessary, like acupuncture, for instance, may not be seen as necessary. Yes, those things are always subject to change. I think the biggest indicator, to be honest, as to whether or not those sorts of issues come up has to do with the economy. Medicaid is a counter-cyclical program, meaning you tend to spend more when the economy is worse, and in those environments, you tend to see states sort of restrict benefits. But we are also in a managed care state, so managed care plans are able to offer beyond what the state has in terms of its plan or even in terms of its optional benefits. So it's sort of a process in flux, but it certainly is something that the state would have to look at as dollars constrict.
And I would add to that we have to realize that 3/4 of the impact of the ACA, 3/4 of the expanded health access has been due to the Medicaid expansion. You might say the repeal is largely about reform of Medicaid. If Medicaid is turned into a block grant, which diminishes in value over time but is more flexible, the decision about what states keep and don't keep, given diminished federal resources, will become harder each and every year.
All right, thank you. All right, I know there were a couple more questions. As I said, we will get to those after Brandi. So, Brandi, if you're ready, you can take it away.
Good afternoon. Thanks so much for having me today. Again, I'm Brandi Slaughter with Voices for Ohio's Children, and I'm going to talk a little bit today about Medicaid, CHIP, and what we think will happen if there's a repeal. So as Loren and Wendy have already spoken a great deal about Medicaid and how it's financed and who it's covered, from a kid's perspective, I just want to mention that Medicaid helps children and families thrive now and in the future. Children who have Medicaid are more likely to be healthy, do better in school, become financially independent adults. Additionally, Medicaid helps families afford care for children with special needs, and it also contributes to family economic security. And for me, I'm a children's issue organization, but children live in families, and families are all types. Some of them are grandparents and children. Some of them are bio parents, and there's lots of. So for us, when we look at the family, it's very expansive in terms of our definition, and so we are concerned about how this impacts seniors, how this impacts people with disabilities, and the like. Nationally, the rate of uninsured kids dropped to 4.8%, down from 7.1%. Put another way, the number of uninsured children declined by almost a third, dropping from 5.3 million in 2013 to 3.5 million in 2015. In Ohio, our rate is 4.4%, and that's down from 5.3%, and that's been under the national average now and in recent years. Several states have fewer than 2% of children uninsured compared to Ohio's 4.4%. Thanks to Medicaid, the Children's Health Insurance Program, CHIP, and the ACA, 95% of children in the United States have health coverage, and that's a historic high. Nationwide, 1.7 million children gained coverage between 2013 and 2015, and in Ohio, more than 95% of children have health care coverage, as our uninsured rates have fallen to historic lows in the wake of the Affordable Care Act. Most newly insured kids that acquired health coverage through the Medicaid expansion and SCHIP, according to a report from the Georgetown University Center for Children and Families, they did so as it relates to that expansion. And employee-sponsored coverage remained stable, covering about 46.5% of children nationwide. Despite Ohio's success, there's more that can be done. And in Ohio, 26,000 children gained coverage between 2013 and 2015, leaving an estimated 115 younger than 19 without health insurance. I'm clicking my slides too quickly. Sorry about that. So in Ohio, close to half of Medicaid's enrollees are children. And as we know, that parents with Medicaid are healthier and better able to support their children's healthy development. When parents have coverage, they can be there for their kids. Families do better overall when everyone has the coverage that they need. That peace of mind that comes with coverage reduces stress and financial burden. Families with Medicaid have greater economic security and are less likely to have medical debt or bankruptcy. Children with Medicaid become healthier adults and have greater academic achievement and attain greater economic success. So what's important to understand, I'm going to talk a little bit about CHIP, the Children's Health Insurance Programs, is that program rests on the shoulder of Medicaid. For every one child enrolled in CHIP, there are 6.5 enrolled in Medicaid in Ohio. And in Ohio, CHIP is also known as Healthy Start. So Healthy Start is CHIP. CHIP is the Children's Health Insurance Program. And it really is an extension or expansion of Medicaid up to 200% of poverty, but yet those children must be uninsured. You can't be on a private plan and then, go to Healthy Start. And it provides the uninsured low and moderate income children with affordable health care coverage. Ohio uses federal funds from the Children's Health Insurance Program to finance Healthy Start. And under Ohio guidelines, and I think Loren had a slide that kind of spoke to levels of poverty, but for children and families with up to 200% of poverty, that would equate to about $48,600 a year for a family of four to qualify for coverage. And Ohio, not unlike some states, chose to expand Medicaid with its CHIP funds versus create a separate coverage program. So as I kind of mentioned, this means children that are in Healthy Start receive the exact same benefits as children enrolled in Medicaid, but the state receives a higher CHIP federal matching rate. In 2016, less than 200,000 children are enrolled in Healthy Start, and Healthy Start federal funding provides stability and predictability for the state budget while ensuring access to quality health care for Ohio's uninsured children. So this is a real quick history of CHIP. It was enacted in 1997 to encourage states to expand coverage to uninsured children. It was reauthorized in 2019 through 2013 in CHIPRA with some additional state options. And then there was some funding extensions through 2015 with the Affordable Care Act with additional federal match, a 23% bump point bump, and required to maintain eligibility. Funding enacted through 2017 in MACRA, but that reduced the state's ability to carry over more than two-thirds of unspent allotment. So there is no entitlement to coverage, and this is a block grant with capped annual allotments. This slide is just to show that Healthy Start is funded through a partnership. It's a federal-state partnership, and the federal government matches Ohio's investment in Healthy Start by a 3-to-1 match rate. CHIP has worked in conjunction with Medicaid to bring down the national rate and Ohio's rate of uninsured children to the lowest level on record. However, CHIP funding is set also to expire September 30th of this year, and Congress must renew the CHIP funding in order to continue the success of Healthy Start. So let's turn our attention a little bit about what we know about past restructuring proposals and its impacts of an ACA repeal. CHIP has been an extremely successful program. It was bipartisanly supported, and it works well with Medicaid to provide coverage to children and families. And leaders in Congress who are demanding a speedy repeal without simultaneously approving a complete replacement plan are taking dangerous risks with our nation's health. Our elected officials in Washington ask us to trust them as they decide how to replace the ACA, yet in the past 6 years, despite voting numerous times to repeal the ACA, they have not been able to agree on a replacement plan. That said, Voices is working closely the debates on the ACA repeal and the restructuring models, and Wendy spoke to this, but the Urban Institute is something that we are also studying, and they recently released a report modeled on the 2015 reconciliation bill that was approved by Congress but vetoed by President Obama. And that report found that the number of uninsured children would more than double nationwide, double with a D, nationwide, if Congress follows through on its plan to repeal the Affordable Care Act without immediately replacing it. As I previously mentioned, in Ohio, more than 26,000 children gained coverage between 2013 and 2015, and the state's rate of the uninsured children also fell to 4.4%, down from 5.3%. So, evaluating restructuring proposals, Voices is most concerned that we must maintain core protections for children in the federal standards, such as a guarantee of coverage, comprehensive benefits through EPSDT, and that is the gold standard in terms of benefits package, and cost-sharing limitations. Congress should keep focusing on the unique needs of children in mind as they consider the future of the Affordable Care Act and ensure that any changes do no harm to children. Looking so quickly. The other things where we see that could possibly have some impact on children and families would be removal of the maintenance of effort provision, so that states wouldn't be required to hold children's eligibility level steady. Coverage for former foster youth up to 26. Again, that's something we're watching very carefully. There was a senator, I believe, yesterday or day before yesterday that did offer an amendment around coverage for former foster youth, and we know that those young people that age out of our system are particularly vulnerable. The loss of parent extended coverage and the impact that it has on their health, the family economic security, and the welcome mat effect on children enrollment. When I talk about those kids that joined CHIP and Medicaid from 2013 to 2015, these were kids that typically were uninsured and only learned that they could have these coverages when parents sought out opportunities through the expansion. So the welcome mat effect definitely caused some more awareness for what people and what families actually qualified for. And then finally, a loss of marketplace coverage for 1 million kids in the United States and approximately 30,000 in Ohio. Some other policy changes that have been proposed in the past, you can see this by substantial changes through waiver activity, the elimination of that 23% bump that I spoke to earlier, and then mandated versus an optional 5-year waiting period for lawfully present immigrant children. So Healthy Start, still essential for all of the reasons listed here. But just as CHIP is important, Medicaid is important, and those populations covered through the expansion, through the ACA, are also important. And, I think this is the point where folks want to know, okay, what can I do? Ohio has always displayed leadership. Earlier in the week, Senator Sherrod Brown prepared an amendment to the budget resolution that would create a budget point of order requiring 60 votes to overcome. And if the Congressional Budget Office determined that the legislation would leave children worse off in terms of health coverage, benefits, or affordability, the final vote, I believe last night, was 49-40, with a couple of Republicans, 2 of them voting with Democrats in favor. So one of the things we can do is just reach out to him and say, thank you for your leadership, thank you for remembering kids. Senator Portman also, he joined 5 Republican senators earlier this week in calling for a delay in the repeal effort until March so that a replacement can be crafted. In the Republican caucus, this stance is wildly unpopular, so just reaching out to him just to also say that we appreciate it. Certainly in speaking with his office, I know that he has some current concerns about the Affordable Care Act, but just having this common sense approach to let's spell out what the replacement looks like first before repeal is important. Our message is still the same. Repealing the ACA without a replacement strategy, it's not a plan. It's a risky step that threatens the health and well-being of children and families. And as the debate continues, it's important that children not lose any ground, and any reforms must build on achievements already made to further improve coverage for children. We look forward to working with each of you to ensure that no child is worse off as changes to our healthcare system are contemplated, and that we can work together to make even more progress for children. That concludes my portion. I'm open to any questions folks may have.
Great. I want to just pause and say thank you to Loren, Wendy, and Brandi. At this point, we are going to open up to questions from the chat bar, and I'm also going to unmute you in just a moment so that you can press *6 and ask questions into your phone if that.
All attendees are muted and may unmute themselves by pressing *6.
All right. I'm going to go back to a question from Kara. And Brandi, I know you touched on this lightly, but how could the repeal affect low-income seniors? And Wendy and Loren, you're also welcome to jump in.
This is Brandi. I would probably kick that question to Wendy. Yes, thank you.
Okay. One aspect to the repeal that could really definitely affect low-income seniors is it could affect the ACA's provision that reduces the donut hole. Many seniors struggle to pay for their prescription medications because of a quirk in the law. And the Affordable Care Act, this is a very pricey piece of health care. The Affordable Care Act reduces the expenses for these seniors, and it will eliminate the gap by 2020. It's hard to say how the repeal would treat this and how it would pay for it if it retained the payment. And I also wanted to add, while we were very hopeful that Senator Portman would work to expand the amount of time for consideration of a replacement, he did not, and he voted for repeal of the Affordable Care Act by January 27th in a 1:30 vote last night on Congress. So we're disappointed in that vote.
All right, and this is a question from Patty. What is considered a reasonable time for Medicaid application processing? They're hearing that it takes 3 or more months locally.
Reasonable time frame is always it's always a big question. I think that the state has done a lot to migrate the system of largely paper-based eligibility into an electronic eligibility system. One provision of the ACA that affected this was a provision around presumptive eligibility, which means that if you're a person who is not covered and you're seeking care at a hospital or a federally qualified health center, that they can treat you up to a certain amount of time, and that Medicaid will retrospectively pay for those services if you are deemed eligible. The issue is, however, that still with Medicaid expansion, there were about twice as many people they expected who enrolled versus what they had estimated. So that puts a strain on a lot of county departments of Job and Family Services, who are also trying to deal with the other systems of eligibility that are not fully integrated. So yes, it can take a long time, but the state has made significant investments and has made investments with dollars associated with the Affordable Care Act to make that system online, make that system integrate with other systems of eligibility around things like supplemental nutrition assistance, or SNAP, and TANF, which is what most people remember as maybe like welfare in the 90s.
All right, and then a question from Nathan. Do any of the three of you have any idea how state vouchers would impact home and community-based services?
I'm assuming that what he's discussing there, what he's highlighting, is this idea of block granting or turning Medicaid from a reimbursement federal match process to some sort of other block or per capita sort of process. That sort of remains to be seen. I think what you have to look at is how these things shift over time and how you manage populations. So if that fundamental way in which the states are funded changes, in a block grant scenario, it essentially ends the entitlement. So that puts every population at risk, and then you're starting to make questions about how you make the most cost-efficient program. And you can see with TANF that led to a lot of disenrollment or people losing their eligibility. In a per capita situation, it might be a little bit different. It might allow for sort of volume to be adjusted in terms of who's able to be enrolled where. But then the question is, well, how do you fund things, and what states get what type of funding? Because, California, for example, which is one of the lower cost states in terms of per capita expenses for Medicaid, might want to be on the same level as New York, which has a very high expense in terms of its Medicaid program. And Ohio is sort of in the middle on all of that. So, I think a lot needs to be determined about how a formula like that would work. In terms of home and community-based services generally, though, one thing I would like to highlight is the fact that the Balancing Incentive Program, which is a program that leveraged higher federal dollars to shift more people into home and community-based programs and services, was financed through the Affordable Care Act. And so if the Affordable Care Act is repealed, that may compromise the state's ability to encourage more people into those lower cost settings, which might increase expenses, but also just might change the amount of dollars that are coming into the state. So there's a lot of mechanical pieces there beyond sort of this shift from the way Medicaid is financed.
All right, thank you. Up, I wanted to share with you what you can do next, which I know Brandi also touched on. As I mentioned at the beginning of the webinar, you will be receiving a follow-up email with the details from today's webinar, and will be included on our email list to get involved further in the future. I've also given you a couple ways to get connected with Advocates for Ohio's Future, Policy Matters Ohio, the Center for Community Solutions, and Voices for Ohio's Children. We are all active on Facebook and Twitter. These are live links, so you can click them now and start getting involved in the conversation on social media. And also, you can make your voice heard. You can call our Ohio Senators, Rob Portman and Sherrod Brown, and tell them that you don't want to see a repeal of the ACA without a replacement. Your voice really does matter, and hearing from you as a constituent is very important, and it only takes a couple of minutes of your time to just give them a call and share your opinion with them to help make sure that we maintain health care access for all Ohioans. And then that is all we have for today. Thank you for joining us. And if you have any further questions, you can email them to me, and you'll also get the emails for our speakers in the PowerPoint presentation, and I'm sure that they would welcome your questions as well. So thank you all for being here, and enjoy the rest of your afternoon.
Yay! It's over.
Thanks, guys.